everyone. Welcome to health maintenance with pulmonary fibrosis, routine testing, symptom management, and the importance of sleep. I am Dr. Amy Hajari-Case. I am the Chief Medical Officer at the Pulmonary Fibrosis Foundation. Thank you for joining our session today. Our speaker today is Mary Beth Jamison. Mary Beth is a nurse practitioner at Banner University Medical Center in Tucson, in Arizona. She graduated with a Bachelor's of Science in Nursing in 2015 at Indiana University Southeast. She went on to graduate with her Master's of Science in Nursing in 2020 at the University of Colorado in Colorado Springs. As a registered nurse, she worked in various clinical settings, including the medical and cardiothoracic ICUs. And since receiving her degree as a nurse practitioner, she has been working at the ILD Center at Banner University in Tucson, which is part of the PFF's Care Center network, where she also splits her time working in the Center for Sleep Disorders at BUMCT, caring for patients with various sleep disorders. She is actively involved in the Pulmonary Fibrosis Support Group in Tucson and the Nurse and Allied Health Network of the Pulmonary Fibrosis Foundation. She is a proud recipient of a DAISY Award in January of 2017 for her work as a nurse in the medical ICU. I'm so happy to welcome Mary Beth today. Thank you for being here. We're excited to hear from you.
My name is Mary Beth Jamison. I'm working in Tucson, Arizona at the Interstitial Lung Disease Clinic here, and I'm very excited to be here. So thanks again. And we're going to be talking about health, maintenance, and pulmonary fibrosis. So some of the big things we'll be discussing are the routine testing, symptom management, and the importance of sleep. So first, we'll get into routine testing. So there's a variety of tests that we can see whenever you're in a pulmonary fibrosis clinic. Let me see if I can get that to go way up top. Okay. So, this can vary a little bit from, each provider. Some things can be a little bit more nuanced, depending on what provider you see and what kind of pulmonary fibrosis or interstitial lung disease you might have. And especially the frequency, so that can change a little bit. But in general, we'll see pulmonary function testing, 6-minute walk tests, repeat CT scans, medication lab monitoring. You might have an echocardiogram, and then we're checking oxygen evaluations. And we'll talk about some of these in a little more detail as well. The first thing that we'll jump into is pulmonary function testing. So again, this frequency can depend on the specific type of ILD that you might have. So everybody's will look a little bit different, as well as the disease course. So do you have something that is more progressive, that we would expect the natural course of this to progress, or those pulmonary function testings maybe to get a little worse? Or is it something that's not so progressive? So that frequency might change a little bit, but in general, we can expect to do them every 3 to 6 months. And in some cases, for some people, we'll do them every 12 months if we're noticing some stability in those pulmonary function tests. Two of the big things that I want to point out are the FVC. So that's going to be one thing that we're looking at pretty frequently on your pulmonary function test. And that is really looking at, in a general sense, how big your lungs are. And then we're also looking at the DLCO, which is how well your lungs can really absorb that oxygen, how well it's getting into the bloodstream. Okay, so again, we're going to talk a lot about trends, and really, again, everything is pretty nuanced. So really talking to your provider about what your pulmonary function tests mean. But, and I'll show a few examples as well in a little bit, but it can be encouraging for someone if we see a very stable or no change in that FVC. Again, if we're monitoring something that we would think would have a more natural decline in that FVC. So, we might see that FVC not changing, and then we would be okay with that. On the other hand, if we're trying to evaluate treatment response for somebody, where you say we started a medication, we expect to see that FVC go up, we might be a little more discouraged if we see it not changing or going down, and we might try to change treatment, pick something else. And of course, another really important aspect to all of this is really looking at symptoms. So, maybe it's not changing, but maybe you're feeling good and you're feeling better. Well, then that is a really big piece of it that we want to make sure we're taking into consideration. because we can treat numbers, that's not very effective if you're feeling okay. So, really looking at the numbers is one thing, but really looking at it, the whole picture and deciding what to expect. And then again, the most important thing is always talking to your provider about your pulmonary function testing. I'm sure many of you have done the pulmonary function test, but just some important things to keep in mind that I always like to point out is that we really want to give our best effort every time that we are doing the pulmonary function test. They can be very effort dependent. So say, you're not having as good a day, you're feeling kind of weak, then your pulmonary function test might not look as good. And that's not going to be a true reflection of what your lung function really is. It could be maybe you were just really worn out, maybe you had a cold. So again, I write here, reschedule if you're sick. We're okay with that. We're okay if it's pushed back a little bit because we want a true reflection of what your lung function is going to be. And then, if you did do it and maybe you didn't feel like you did as good as you could have because you weren't feeling well, that is definitely something that, we can talk about in the appointment so that we're not making those treatment decisions or, making decisions based off of something that may not be a true reflection of your lung function. And then deconditioning can make results look worse as well, whenever they might not actually be. So, maybe you were hospitalized and you're, again, feeling really weak and deconditioned, your muscles aren't as strong. So that can reflect on your pulmonary function test. So again, I'm going back to the trends. We really want to make sure we're looking at trends over time and discussing those with your provider. So this is an example of those trends, and I'll kind of walk you through this, but this is what one of the real pulmonary function test reports looks like. So there's a lot of numbers on it. And, again, two main things is that FVC and our DLCO. So we're going to look in just these two columns here, really trying to help narrow it down whenever you have all of these numbers and you're trying to decipher what they can mean. So if we look at the bottom, we have our dates. So we have January of 2022, it's about 2.5 years, and somebody's FVC was around 2.7. Okay, and then we're looking at that compared to their FVC at the top of the column, which is 2.8. So we can see over that time period, that FVC number has stayed the same and a little bit of improvement. So maybe they felt better whenever they were doing it. Maybe their lung function improved a little bit, but in general, we can, contribute some of that to the test variability, how they were feeling. But overall, we would say it's a very stable FVC. In our DLCO column, we see that, again, in that January of 2022, so at the very bottom of the DLCO column, the red arrow, we have that DLCO of 15, and then we're checking it over time, and we would have a current value of 11. So that has declined some, and this would be someone that we would say, well, maybe that is progression of the pulmonary fibrosis, so maybe a little bit of worsening. But also we could look at other causes. So this would be something that do we need to get an echocardiogram to look at the heart? We would look at other things that could be causing that as well. So overall, we'd say that FVC is pretty stable. In the DLCO, we've seen a little bit of a decline in that. Another example here, we have our FVC column in blue and our DLCO in red. Real pulmonary function test report here, and we have our FVC of 2.4 in the bottom of that blue column. And over time, we see it maybe about the same whenever it was done in October, but that green, the 2.6, we see quite a bit of an improvement. So we see it improved there. And again, our DLCO also improved. That green number, the 17, see that's improved. And in this pulmonary function test, it improved so much because we started therapy. We started a new medication. So, if we had started that medication and those numbers were still going down and the patient wasn't feeling good, they still felt very short of breath, then that would have been something we would consider maybe changing therapy. Something else I'd like to talk about is the 6-minute walk test, because I'm sure that's been done for many of you a few times. And really, we're using this to evaluate that exercise or functional capacity. So you might have heard the question, how many flight of stairs can you climb? It maybe takes the place of that a little bit more because some people don't have stairs. That might be more up to the individual person of how they might feel when they climb stairs, or can't even answer it because you might not really take the stairs. So this 6-minute walk test can really put a distance on that for kind of our information, and it can help assess prognosis as well. So if we've seen a significant decline in that 6-minute walk test, and it might give us a better idea of how that person is doing. Evaluate treatment response as well. So you definitely, oxygen therapy can improve that 6-minute walk test. And what we're looking at as a good difference is a difference of 25 to 33 meters. So say we've done a walk test, maybe didn't do as good as you'd hoped. The numbers are kind of low. And we noticed your oxygen was low as well during that. If we applied oxygen, maybe you could walk a little bit further. But we would say that was treatment success with the oxygen. It allowed you to be more functional, do a little bit more. And then the pulmonary rehab can increase 6-minute walk distance, so improving deconditioning and exercise. What 6-minute walk testing is not good at, it's not really a good measure of disease severity. Somebody could have a severe pulmonary fibrosis if they're using oxygen and staying active. Maybe they can walk pretty far and they do okay on their walk test, but they do have a more severe disease. So that can not, it's not really a good measure. It's not telling us, I can't look at that 6-minute walk test and say this is a very severe person, because those are just the numbers. It's just telling me that they can walk really far and their oxygen won't drop, but maybe they had oxygen on. Some other repeat testing, routine testing that we can do. Again, this can kind of change from provider to provider a little bit. CT scans, we can do them every 1 to 2 years. Really depends on somebody's comorbidities. So say we're following a lung nodule, you might get a CT scan probably a little bit more frequently. And then it can depend on progression as well. So, if somebody is really stable, their pulmonary function testing looks good, they feel really good, then we don't necessarily need to get that CT scan every year or every 2 years necessarily. And some providers like to do that, and patients too, because they really want to know what things look like, but we don't really have specific guidelines that are telling us to do these on a specific basis. And then lab monitoring, that can be routine based on which medications you're on every 3 to 6 months. Sometimes we can also recheck antibodies for maybe connective tissue disease. Maybe you had them initially and they were negative, but if you're having new symptoms of joint pains everywhere, muscle aches, then we might recheck those maybe a year or 2 later. Echocardiograms, we can get those done maybe every year, depending on how you're doing. And then oxygen evaluations, of course, we're doing those with the 6-minute walk test. We can do them to assess treatment response. So if you've started a new medication, we want to see if that's going to improve your oxygen. Okay, now we're going to get into some symptom management. And here we're going to talk about cough, shortness of breath, oxygen use, which we'll go into in some detail. Mucus and airway clearance, so some techniques to help with clearing mucus. We'll talk about fatigue, pulmonary rehab, and side effects of medications, because those can be pretty significant as well. So the first thing I want to get into is cough, which is a very common symptom in our ILD clinics. And I look at it kind of in tiers. So the first thing we want to make sure we're addressing is allergies, postnasal drip, and acid reflux, because these are things that can be common, and then they can also be very easy things to treat initially. There's a lot that goes into cough, but these are some things that can be easier to treat if you have them. Acid reflux medication is not going to work if you don't have the acid reflux or the acid coming up at all, but we can try them initially to see if there's going to be any response. Then, if there's any wheezing, some people can respond really well to inhalers. Not everyone. Sometimes inhalers aren't very helpful, but it can be for some people. And then prednisone, if somebody needs like a low dose of prednisone to help with their cough, then we might have them on that for a period of time just to help symptomatically. And then on occasion, we'll have people go see ear, nose, and throat provider to kind of visualize the airway, just the upper airway, or maybe your throat or vocal cords. And then on a rare occasion, we can use a cough syrup or opioids. And this would be something that I would probably personally have done maybe through a palliative care provider or speaking with after maybe like a multidisciplinary meeting or something, really discussing, if we looked at all of the other options. So it's more of a last case. And if it's really severe, really affecting your quality of life, and we've gone through all of the other steps. Another touch base on cough with the reflux a little bit more, but we look at GERD, so acid reflux. And one thing I want to point out is that reflux can be silent in some people. So you might not feel like you have heartburn, but if you're lying down and that reflux can kind of come up and cause a cough, irritate your vocal cords, and cause you to cough when you wake up in the morning, and you still might not really have heartburn from it. So again, I go back to, we might try that acid reflux medication for a while to see if it's going to help initially, even if you don't necessarily feel like you had the acid reflux. But it's a very, very common cause of that persistent cough. So we like to look at that first. And then another type of reflux, laryngopharyngeal reflux. You might have, so if you notice like hoarseness, pain with swallowing, clearing your throat quite a bit, but there's really no phlegm, no postnasal drip, then again, that would be something we would have you maybe go see an ear, nose, and throat or a GI doctor for any of these things for your stomach. Another thing for symptom management is, of course, treating shortness of breath. And I just wanted to point out, kind of up top, that shortness of breath does not necessarily mean that you need oxygen. And I think that's important to point out because we want to validate that, yes, you can feel short of breath, even if your oxygen levels are not low. Because people can be kind of confused, like, why are my oxygen levels, or why am I short of breath if my oxygen's fine? Is this really happening? Am I crazy? Absolutely not. This is something that you can still experience, even if your oxygen levels are good. So it can also be caused by increased work of breathing. So maybe you're just breathing fast, your breathing rate is faster. Extra body weight, being overweight or obesity can cause some shortness of breath. Anxiety, deconditioning, so weakened muscles, feeling weak. And then another thing to look at is your heart. So you can be short of breath, if you have a really rapid heartbeat. We want to make sure we're looking at things like atrial fibrillation, which can cause you to feel short of breath if that heart is really racing. So we might, have you see either cardiology or your primary care to maybe monitor that over some time. In general, for shortness of breath, relaxation, psychosocial support, modifying activity levels, so pacing yourself. That can be very important. Just maybe not doing as much one day and spacing that out over a few days so that you're able to rest in between. And then using a fan for increased airflow, like in the picture here. You can have a fan, that feeling of air blowing across your face has been shown to help with some of that shortness of breath. So even wearing something like the fan in the picture, it's constantly kind of blowing some air can relieve some of that. And then of course, oxygen therapy, if your oxygen levels are low, wearing the oxygen can help with the shortness of breath. It's not likely to provide benefit though if your oxygen levels remain normal. So then we might want to look at some of the other, causes of the shortness of breath. And then we really want to use oxygen to maintain normal activity levels. So we don't want somebody doing less because they feel short of breath. We would rather prescribe oxygen if needed so that you can maintain those activity levels and stay active. And then again, relaxation, maybe some anxiolytics if you're having anxiety. Managing secretions is important. So if you're having a lot of mucus, we can do some airway clearance, and I'm going to talk about airway clearance in more detail coming up. But really managing those secretions and getting those out can help with shortness of breath. And then again, opioids, typically prescribed by a palliative care provider. At least, for me, I would be more comfortable with that. But that can help with some shortness of breath. It's also effective for cough. So oxygen, we'll talk about the different kind of types of oxygen and different, like the different equipment that could go along with that. So we have our big home concentrators. They can go anywhere, from that 0.5 all the way up to 10 liters. They're continuous oxygen. They're electricity dependent, so you will need that backup if electricity is out. And usually the electrical companies, if you get a note from your provider's office, they can know to have emergency power, or if the power is out, to kind of provide you with power quicker. Then we have our portable concentrators. These provide pulse dose flow. There are a few that provide continuous flow, but for the most part they're the pulse dose. They're in general, they're lightweight. The heaviest one is 18 pounds. That's a portable concentrator. That's one that would roll kind of on the ground, maybe like a travel suitcase size. And then the most lightweight one is around 4.3 pounds. There's only one device that provides up to 3 liters per minute continuous. So I think it's really important to kind of keep in mind with these that the settings on the portable concentrators don't equal the continuous flow. So maybe you're at a setting of 6. That doesn't mean you're getting 6 liters, per minute of oxygen continuous flow. That's just a setting. Maybe you're getting, 2.5 or 3 at that setting of 6. So I like to point that out too, because that, if you're walking around with one of these and you need to turn it to 6, that doesn't mean you're getting worse and you're requiring more. You're probably, again, only getting that like 2.5, 3 liters, which is what you might be on that big concentrator whenever you're on continuous oxygen. And then these can be used for air travel as well, the portable ones. Then, of course, we have our cylinders. We have the large E-tanks. They're 1 to 6 liters per minute. They can last 1.5 to 2.5 hours. If it's that continuous, you can also put a pulse dose regulator on there, and then they'll last a little bit longer. And then we have the small bead tanks that you can put in a backpack. Again, you can do pulse or continuous with that. This is an example of what one of my patients did with the with their big tank, because they didn't want to carry it around, so they were using the walker primarily, really just to carry their big oxygen tank. And I've heard of people even putting 2, slinging 2 on there, because you don't want to walk around with 2 of them. But this can just be a way to kind of carry those around. Some other things with oxygen is you can get an oximeter. So what an oximeter is it's the picture of the person wearing it around their nose, and then the pendant hanging on the chest. So typically, whenever we have continuous flow oxygen, some of that oxygen is lost because we're not breathing in during the entire minute. So whenever we're breathing out, that continuous flow is just kind of getting lost, some of it. So then that lost oxygen is kept in this reservoir, which is the oximeter, is the reservoir. And then it can provide a little bit higher percentage of oxygen, and it can maintain your cylinders a little bit longer as well. And these can have more benefit with liter flows over 4 liters per minute, and then they're compatible with both cylinders and concentrators. You can also get a humidifier to help humidify that oxygen. Really should be used with those liter flows over 4 liters per minute. And then your nasal cannulas, of course. So you can have your standard cannulas, a higher flow cannula if you're needing like 6 to 15 liters. And those higher flow cannulas just have a little bit larger faceplate under the nose, just a little bit larger. And that's just a little reservoir. So airway clearance for symptom management. So this is if you're having a lot of mucus. We don't want to let any of that mucus really sit in the lungs. What that can do if you're having a lot of mucus that's just kind of sitting there, that can be a petri dish for bacterias, bugs, viruses. So we really want to make sure we're mobilizing those secretions and getting them out. So some ways to do that is this airway clearance. So again, there's a lot of words on this slide, but what it really is you would use a nebulizer, probably nebulize some albuterol first. And what albuterol can do, kind of 2 things. It can help open the airways up a little bit if needed. But it can also relax them, because the next nebulizer you would do is like a hypertonic saline, a salty saline solution, and that can irritate the airways. So that albuterol beforehand can help kind of relax things. But what that salty nebulizer will do, the hypertonic saline, is it helps loosen those secretions up. It helps get them so they're not as thick. And then after you do that nebulizer with the salty solution, saline, you would do some maybe chest physiotherapy, or some, again, trying to physically mobilize the secretion. So maybe having someone tap on your back, trying to bring them up. Some people have the vests. If you've seen those, that's maybe more used if you're having really, really copious, really, really thick secretions with maybe some other diseases. But you could use one of those chest devices, but you're really just trying to mobilize everything. You're really just trying to get things moving physically, in the chest. You can also use a flutter valve, like an a cappella device, flutter valve in general. But what it's doing is it's essentially, again, helping to mobilize and move those secretions so that you can get them out. And then you can do some coughing. So there's something called a huff cough that can really help. It's a very effective cough in helping to bring some of the mucus up. And here again, I have coughing, huff cough, and kind of an explanation on how to do that. So you're going to repeat that a few times during your airway clearance routine to plan that cough for after your nebulizers. And then again, exercise, keeping active to avoid that deconditioning, which can make it harder to have a better cough to bring up the phlegm. So fatigue is absolutely something that we see in our ILD clinics, and it can have a high burden for our ILD population. And it can contribute to, it can contribute to anxiety, not able to work as much, and it can be a side effect of medications. We want to make sure we're looking at treating sleep apnea if that's causing some of the fatigue, and then we want to make sure we're looking at alternate causes of fatigue. So thyroid, depression, anxiety, stress, anemia are a few things. And I know I talked about pacing yourself earlier, but again, that's another very important thing with fatigue and shortness of breath. So just taking maybe a little bit extra time to do all of the things that you want to do over a few days rather than trying to do everything in one day. Wearing oxygen can help, considering the sleep study, and then exercise. And we'll talk about sleep studies again in the sleep section. Another really important thing with symptom management is medication side effects, which they can be very, very common. We have our antifibrotics, and a lot of people have nausea, vomiting, diarrhea. We want to make sure we're maintaining adequate hydration. Some of them come with the antidiarrheals, so we can take those as needed, anti-nausea medication. We also can do, a dose reduction or temporary interruption of the therapy. So, if you need to stop it for a few days to really let your body reset, we're okay with that. And for some of the medications like pirfenidone, if you're going to stop it for more than 2 weeks, you might need to restart a taper. That would be something I would talk to your provider about. But if you do need to stop it for an extended period, you might want to restart a taper with some of those medications. And then taking the medication with food as well can help. Then we have Cellcept. A lot of people get upset stomach, so make sure you're titrating that slowly, taking your time. And then there are some formulations that are a little bit easier on the stomach. So if that's significant, that upset stomach is really significant for you, just make sure you let your provider know, and we can change it maybe to a different formulation. And then, of course, steroids have a lot of side effects. They can be really good to help with some symptoms, but we definitely want to make sure we're addressing all of the side effects as well. Insomnia, weight gain, osteoporosis, blood sugars, all of those things. So some things, if it's having like an insomnia, you can take them earlier in the day. If you're splitting it between 2 times, I would definitely talk to your provider first if it's safe that you could take them maybe earlier in the day at one time. And then consider lowering the dose. We always want to be on the lowest effective dose to help our symptoms, but to avoid those side effects. So maybe trying, can I go 5 milligrams less and see if I still have the same benefit from it. And then, of course, more on prednisone because it is so common. So again, dose and duration as low as possible. We want to make sure we're doing weight bearing and resistance exercises to prevent that bone loss. We want to avoid smoking, excess alcohol, taking measures to prevent falls, making sure we're getting enough calcium and vitamin D. So calcium is 1,000 to 1,200 milligrams a day, and vitamin D of 800 to 1,000 international units a day. And then, as appropriate, getting that DEXA or bone mineral density scan, and really making sure you have good follow-up with the primary care or whoever else would be following for those types of testing. And sometimes, we'll even do them, in our interstitial lung disease clinic if somebody's been on prednisone for a long time. And then pulmonary rehab is very important with symptom management. So what pulmonary rehab is, it's really a structured exercise program. So what we're doing in pulmonary rehab is we're monitoring vital signs. We're helping you with exercises that you can do safely while we're monitoring you to build up those muscles that can help with your breathing and help with your functional capacity. It can improve energy, it can improve focus, mood, overall sense of well-being if you go through a pulmonary rehab program. And, in some cases, if somebody is doing really well, we might not necessarily need to order it right now. And maybe on a follow-up, you could have had maybe a surgery for something not related, and that's really got you down. You're not exercising as much. And at that point, you start to become deconditioned and you're not able to do as much. Well, maybe we can think about a pulmonary rehab program at that time because we need to rebuild that strength that you maybe once had so that you can kind of continue on with those those strength of your muscles. Some online pulmonary rehab resources. So the Pulmonary Fibrosis Foundation does have a really great online pulmonary rehab toolkit on their website. So there are videos that can show you safe exercises and, monitoring of your vital signs while you're doing those that can help with your breathing. And then some other Live Better with Pulmonary Rehab. It's a great resource. And then the American Association of Cardiovascular and Pulmonary Rehab is another great resource to kind of learn about what it is, the benefits of it, and how to do it. Okay, so the next kind of session we'll go through is the importance of sleep. So we're going to talk about why do we sleep? What is the purpose of that? The adverse outcomes of insufficient sleep, sleep disordered breathing, and pulmonary fibrosis. So things like sleep apnea, low oxygen levels, and then we'll talk about some ways to improve our sleep. So sleep is essential to health, and really before the 1950s, sleep was thought of as a really inactive process. So a time whenever our brain and our body were inactive, nothing was really going on. We were just kind of not doing anything. But again, sleep is really essential to our health. We've really come to learn that it can help with memory, learning, brain plasticity. So how well, are we able to take in all the stimuli during the day, and we're really working through that while we're sleeping? Emotional regulation, judgment, decision-making, growth and immunity, which we'll talk about. So that short sleep duration can be associated with a variety of heart health outcomes. And it's really recognized from the American Heart Association as a risk factor for poor cardiac outcomes as well. There have been some studies that have shown that impaired response to a flu vaccine after 6 days of sleep restriction. So sleep is very essential to our immune system as well. It's also been poor sleep has been associated with increased susceptibility to colds, the COVID-19, flu, and upper respiratory tract infections. And then, multiple studies have shown an association between sleep deprivation and obesity. What the main thing that the research has shown us is that inflammation is identified as a possible mechanism for the increased cardiovascular risk. And it's really full body, like systemic, full body inflammation that could be causing those adverse health outcomes as far as your heart. So it's been associated, poor sleep, with central obesity, elevated glucose, so your blood sugars being higher, high blood pressure, low HDLs, high cholesterols, and then metabolic syndrome. So these are all risk factors for cardiac disease, and your sleep affects all of these. Of course, we have to talk about sleep apnea. And really sleep apnea, what that is the closure of your airway while you're sleeping. So it's the closure or the narrowing of your airway while you're sleeping. It's the most common sleep-related breathing disorder. And some of the complications of untreated sleep apnea, and this is where some of that inflammation or that cardiac risk can come from. So whenever we're asleep and that airway is closing, our oxygen levels are dipping up and down all night, and that's that intermittent hypoxia. And there's a lot of information that up and down dipping of our oxygen can be more harmful and more inflammatory than maybe just a chronic low oxygen level. So it's that jumping up and down of those oxygen levels. The untreated sleep apnea can activate the fight or flight response while we're sleeping. So instead of our body really getting the rest that it needs, it's like our body is running a marathon. We have this fight or flight response, this sympathetic activity going on while we're asleep. We have a lot of intrathoracic pressure swings. So if you're trying to breathe against a closed airway, you're trying to take a deep breath, but that airway's closed, it's putting a lot of intrathoracic pressure on your heart, on your organs. So that can, again, cause some inflammation. The systemic inflammation, we have the GERD, possible chronic microaspiration. So again, trying to breathe against a closed airway, that's pushing some of the stomach contents up and possibly causing some aspiration of stomach contents into the lungs and possibly causing a little bit of scarring in the lungs. And that's something, that's being looked at now too, in research. And then another complication of kind of untreated sleep apnea is pulmonary hypertension. So an important question to ask is, does pulmonary fibrosis or is having pulmonary fibrosis a risk factor for sleep apnea, obstructive sleep apnea? And it could be because, whenever you have decreased lung volumes with pulmonary fibrosis, so our lung volumes are decreased because that scarring in the lungs kind of squeezes everything in. It pulls everything in, the scarring does. So we have decreased lung volumes. What that can do is it reduces the upper airway stability. So this is our upper airway. Whenever these lung volumes are decreased, this airway is not as stable. It's not able to keep itself open as much. And that can lead to that upper airway collapse or that sleep apnea whenever we're asleep. So, sleep pulmonary fibrosis could be, it's not something that's been, set in stone necessarily, but it could be a risk factor for sleep apnea because of those decreased lung volumes and the reduced upper airway stability. Then we have insomnia, another common sleep complaint. So some predictors of insomnia, oxygen use. If you have low oxygen levels at night, oxygen use is actually associated with less insomnia. So those oxygen levels, if they're chronically low, that could be keeping you up because you're uncomfortable, you're short of breath. Smoking is associated with more insomnia, and then sadness, anxiety, depression is also associated with more insomnia. So can increase risk of exacerbations, insomnia, increase risk of those exacerbations in COPD, but there's no research in interstitial lung diseases yet. So a lot of the information we have is kind of based on the COPD population, but with chronic lung disease in general, we can try to apply some of those to our interstitial lung diseases. And so why do we have this increased risk with COPD or chronic lung diseases? Well, again, we have that increased sympathetic activity. That's that fight or flight response. So that's what could be going on if we're having insomnia. We're kind of stressed out, our body's not getting the rest, that increased inflammation. The immune system is not regulating as well as it should be. And then we have the improper use of hypnotics, which can lead to exacerbations. And again, like we've looked at COPD, but we might be able to apply some of this to our interstitial lung diseases as well. So if we're looking at improving our sleep, one thing that we can do is requesting a sleep study from our provider. You can in some cases you can do them at home. In some cases we want to make sure we're doing them in a sleep center. But getting that sleep study to see, is our oxygen low? Is our airway closing? Do we have that sleep apnea? Looking at all of those things. And then also looking at sleep hygiene. So a regular bedtime, a regular rise time. That regular wake up time is one of the most important things for regulating those sleep rhythms. Avoid napping is maybe a more tricky one. Napping can be okay if you're not having trouble sleeping, or if it's not causing you to have problems going to bed whenever you want to go to bed. So if it doesn't disrupt your sleep, if it doesn't disrupt your lifestyle, napping can be okay. But in general, if you're really struggling, then I would try to avoid that nap. And we're really building up that sleep drive to sleep at nighttime. Limiting our caffeine, limiting our alcohol. Alcohol can make our sleep worse. Avoiding nicotine, trying to get exercise during the day, keeping that sleep environment quiet and dark. Avoid time checking, which can cause a sleep anxiety. If we're waking up at 1, we're worrying, can I go back to sleep by 1:30? Can I go back to sleep by 1:45? So really time checking can disrupt our sleep. If we've woken up, we're not able to fall back to sleep. And then avoiding eating too close to bed as well. Again, waking on the same time every day, even on the weekends with an alarm, can really help regulate our sleep rhythms. Establishment of a stable bedtime every day, even on weekends. We want to make sure we're getting bright light in the morning. So, you don't have to come out of your room, turn all the lights on, but, let your eyes adjust and then maybe turning all of the lights on, getting out in the sun for 30 minutes a day to, get the sunlight. But then in the evenings, we really want to avoid bright light. So we want to avoid the light in our eyes. So only dim lights, no overhead lights in the evening. Our eyes are really sensitive to the light. And so it won't produce that natural melatonin that we need if we're having that stimulation in the evening time. Some people, you can take 3 to 5 milligrams of melatonin about 30 minutes before your bedtime. Melatonin is not supposed to make you drowsy. It's not a hypnotic. It's not going to knock you out. But again, it can help regulate some of your sleep rhythms. But don't see it as a treatment failure for melatonin if it's not, making you so drowsy that it's knocking you out. And then really remembering that first line therapy for insomnia is cognitive behavioral therapy. Okay, and what that is you can have cognitive behavioral therapy for anything. You can have it for anxiety, depression, PTSD, but there's a specific cognitive behavioral therapy for insomnia. So it's really looking at things, behavioral mechanisms behind why you're not able to stay asleep or fall asleep. So sleep restriction, sleep hygiene looks at some of those types of things. Okay, I think I've gone through everything.
Oh,
So
sorry.
nope, you're fine. Should I stop
I'm,
share or should I leave it up on the screen?
you can leave it up or you can take it down. I think we're okay either way.
Okay,
Um, Mary Beth, thank you so much. That was great information for everybody. We already have some good questions that have been
great.
submitted, but I will remind folks that if they would like to submit any additional questions, to go to their question and answer tab on their control panel at the bottom of their screen. And Mary Beth, if you're ready, I'm going to ask a couple of questions of you
Yeah,
on some of the topics that you've covered. Um, one question I wanted to ask is, you were talking about the frequency of CT scans and how we don't really have clear guidelines for the frequency of CT scans for monitoring, although it is a linchpin for diagnosis in interstitial lung disease. Can you talk about a couple of indications where maybe just for comparison's sake, where somebody might have a CT scan more frequently and their
mhm,
doctor might say, oh, we need to get one in 3 months or 6
mhm,
months or
yeah.
repeat in 6 weeks or something like that.
Yeah, absolutely. So we can see maybe you need a CT scan in 3 months. So say you come in with some shortness of breath and we're looking at your CT scan and it's looking like a type of a pattern or type of imaging that would be responsive to a medication like a prednisone or something that's anti-inflammatory. And so we're starting you on a medication over time, maybe prednisone for a couple months. And maybe you do feel better. So we want to see, let's get a CT scan after you've been on that prednisone for 3 months to see if some of that imaging that we were looking at, a while ago has cleared up. Maybe that CT scan looks better. Maybe it was just inflammation and some of that's gone, but it can be hard whenever we're looking at a CT scan for the first time to tell sometimes if that's inflammation or if that's scarring in the lungs. And so getting that repeat CT scan can help us maybe tease out, was this an acute process or is this something that's more scarring and might be there? So we might want to get that quick follow-up CT scan to see if that cleared up at all, with treatment.
Absolutely. That's great. I also sometimes think of things like other, non-ILD indications that can coexist with pulmonary fibrosis or interstitial lung disease, like a pulmonary nodule, for example, a spot that you saw there, that we actually have pretty clear guidelines based on a person's risk factors and the size and character of the imaging of the nodule and imaging, and that might lead to somebody getting a more kind of routine CT scan every x amount of time for monitoring of that purpose. And I think sometimes that's not always clear to folks, like what the indication for why they're getting new imaging might
Right,
be.
absolutely.
We had a great question about uh, coughing and some of the things that trigger cough. You talked about a few of them, but I definitely noticed that some folks will cough more as they talk more, and so they'll say, maybe I was talking on the phone to a friend, I started coughing, I couldn't stop, or even in clinic. I've noticed that myself as I'm getting over a cold or something, maybe as I start to talk a bit more, and I do talk too much, that I maybe start coughing as a result of that. Um, Thoughts on maybe on why that might be? I don't know. It's always clear, but and what folks might do about it.
Yeah, absolutely. And I think you made a good point. Sometimes it's not exactly clear. We have to it's hard to pinpoint exactly what the cough could be from. If you're feeling like you're coughing more, as you've been talking more, you could, maybe there's a buildup of phlegm that's hanging out behind your throat, maybe some postnasal drip. And maybe even it's coming from the chest a little bit. So as you're talking, your that phlegm is coming up a little bit. And so we want to assess, is there infection? Is there just that chronic phlegm that some people have? Or if it's the postnasal drip, really, focusing on that and seeing if that will help.
think that's a great
Do you
idea.
have any other thoughts with that?
Yeah, I also think sometimes as we're talking, I think sometimes we dry out the back of our throat as the, airflow goes by more frequently, more quickly. And so I think oftentimes people, I have had folks tell me they get benefit from maybe using a cough drop to keep their throat a little less dry, having some water nearby so that doesn't happen.
Yeah.
And the other thing I like to look at is, are you having low oxygen levels while talking? Is
Mm-hmm.
that level of exertion causing, because that sometimes can also trigger people to cough, is just those low oxygen levels, and making sure
Yeah.
that those are adequately covered when that's
Yeah,
happening.
that's a really good point.
I have a good question about, let's see. I have one about sleep apnea and using oxygen and, so let's say, a CPAP mask. And maybe is it really necessary to use both? How do you integrate them? And can it be better? Is one better than the other, or a combination of both better than one alone for
Mhm.
pulmonary fibrosis?
Right. Yeah, it really depends on, as many things do, each specific person. So you might not benefit from the CPAP at all if you really don't have sleep apnea, and you might just need oxygen. So if you are using oxygen at night, but you're still feeling really crummy, you're not feeling very good, you're fatigued, you're still snoring, there might be sleep apnea going on that we need to then introduce the CPAP machine. And at that point, you would have an in-lab sleep study because you're already on oxygen. So we want to make sure we're monitoring that oxygen during the sleep study. And then they would apply the CPAP, treat your sleep apnea, and then put the oxygen into the back of the CPAP machine. So the CPAP itself isn't delivering any extra oxygen. It's just a little bit of air pressure to pop that airway open so that it's like a stent. It's like a pneumatic stent to pop that airway open. So it's not necessarily oxygen, but then if your oxygen is still low while even your sleep apnea is treated because you have a chronic lung disease, then they can plug the oxygen in. So, your airway is staying open, your oxygen levels are appropriate, and, both of those things are treated. So, ultimately, if somebody really can't tolerate a CPAP machine, I think that, it's really important just to make sure you're wearing your oxygen if needed. So I would say that in the least, but really treating, if there's sleep apnea, treating it if you're able to.
Absolutely. I think that's great advice. I have some questions about using, you mentioned, okay, let me start over. You mentioned potentially using melatonin as a sleep aid for those folks who are having trouble with insomnia. Um, do you have advice on other over-the-counter medications for sleep? I know Benadryl is sometimes used, or in the Unisom branded. It's this, same medication for people to use to try to help with insomnia.
Yeah, that would be the only two other things that I would say over the counter would be something like Benadryl or Unisom. If someone's going to look at getting something over the counter. And I think it's really important, again, going back to the melatonin, you don't want to be using too much. So if it's not making you drowsy, maybe I need more, maybe I need more. We really don't want to be taking more because, one, there's not a lot of research saying more melatonin is better. But we can also get maybe just more side effects and no more benefit if we're going past that 3 to 5 milligrams. And a lot of them, we don't even know how much is in them. So you could say 5 milligrams, there might actually be like 10, 15, 20 milligrams in that a dose. So, because it's not regulated. So we don't want to be kind of doubling up just because we feel like it's not working. But, over the counter, just things like the Benadryl or Unisom.
Absolutely. Um, I have a question. It's a two-part question. I'm going to ask the first part, then I'll ask the second part. What do you recommend for folks to treat their acid reflux? There are a number of over-the-counter medications that if you walk into the aisle, you can be a little overwhelmed
Mhm.
with. Is
Yeah.
there is there something that you usually generally recommend for people to start with?
Yeah, something over the counter. You can, I mean, some people can use Tums. We don't want to be just like swallowing Tums. If we're doing something like that, that might be a time we might need to move on to a different like, medication. So I would say starting with something like omeprazole or esomeprazole. which is Nexium. So those are some things over the counter that you can find at the store. So those are things we can prescribe as well, but you can find them over the counter.
Perfect. Yeah, those are that class of medication, a proton pump inhibitor. Many of those are over the counter, and they are also available by prescription. But I think the over the counter versions, and they come in generic forms, but they end in usually azole of some kind or another, omeprazole, and so on. Um, and and I think consistent use of those, if you need something regularly, consistent use of those is typically the best way to go about it, instead of using it kind of on an as needed basis. I feel like doesn't work as well, but you're really going to those types of medicines if you're having more frequent episodes of reflux in the first place. What everybody's got sort of their favorite way of managing this, I think, and the different parts of the kitchen sink I think they throw at it, especially in my part of the world where it's always humid and always warm and nothing dies and everybody's got postnasal drip.
Yeah.
How do you approach that with folks, to try to get them some relief?
With allergies. Yeah. Yeah. So initially, if they're not, maybe taking an antihistamine. So this would be something like Zyrtec, Claritin, Allegra, and taking it regularly. So really making sure we're consistent, taking it every day. So really assessing compliance. If you've been taking one for a long period of time, maybe switch to another one, see if that's going to help. And then on top of that, using a nasal spray can be helpful to really help with the inflammation in the nose. So this would be something like Flonase that you can use. Like it's usually 2 puffs, like each nostril daily. So you could try that on top of the pill. So like the Allegra or Zyrtec or whatever that is. And then if we've tried those things and we're still not getting a lot of relief, and it's still really bad, really bothersome, sometimes I'd have you see either an allergist or an ENT for other suggestions. What do you think? What is your strategy?
I am the same way. I also counsel people to avoid the Afrin. So the
Yeah.
over-the-counter nasal spray that kind of opens
Mhm.
you up really fast. It's great for a day or two, and then after that actually makes things worse and can be physically dependent. You can become physically dependent on it. So I always advise people to avoid getting into that trap in the first place, unless there's a very
Yeah.
specific reason for it. That's something.
Absolutely.
Let's see. We do have another sleep apnea question
Mhm.
about uh, the use of a mouth guard. So there are folks that have more mild sleep apnea. There are different ways of treating it that are coming out. Implantable devices and mouth guards have been used for a while. Do you ever recommend those?
Yeah. So usually I would start, unless someone's really, really, they know they really are not going to want to use the CPAP. I usually say start with the CPAP. We'll do a trial for about 3 months. We'll reassess, see how you feel with it, see if it's comfortable or if you're benefiting from it. If it's not, if you have mild sleep apnea, you can use the mouth guard. So what that does is it kind of locks the jaw in place, but it works by moving the lower jaw forward to keep that airway open while you're sleeping. And that can be effective for mild sleep apnea. If you have moderate to severe sleep apnea, it's not going to work as well. It'll still work, but it might lessen the degree of your sleep apnea, but it's not going to take it away. So you'd be wearing it, but you might still have symptoms. You'd still have moderate to severe sleep apnea. But it can be effective for that mild sleep apnea, so people can definitely use those. And then if you have more moderate to severe sleep apnea and you can't tolerate the CPAP, then that Inspire device is another option. And that's an implantable device. It goes under the skin, just under the clavicle. And what that does is there's a wire that kind of tunnels to the nerves that move your tongue. So whenever your airway's closing at night, it stimulates those muscles to move out of the way. So that can be it's a little more invasive, initially, but it can be a really good option for people with moderate to severe sleep apnea that needs to be treated. And you might still need to wear oxygen, if you have an Inspire, because if you still have that chronic lung disease, your oxygen level still might be low at night, but your sleep apnea would be treated. And there's, that host of other complications from untreated sleep apnea.
Sure. Yeah. And do you have patients that use a mouth guard and oxygen? You feel like that's something?
Yes, yeah, same with the mouth guard. If you have mild sleep apnea and you're using a mouth guard for it, you might still need to use the oxygen.
Perfect.
Yeah.
Mary Beth, thank you so much for this really informative
Yeah.
presentation. We are at time,
Okay.
but I really appreciate your time and all that you do for the pulmonary fibrosis community.